a fairly sensitive test for nerve tension irritation. And it has a very high degree of specificity if the symptoms are located below the knee. Okay, so it's sensitive, it's a specific test. It's evaluating the neurodynamic behavior of the entire meningeal system, because it's examining both the spine and the lower extremities. So the slump test, as it says, is affecting a lot of different tissues, and your interpretation of the test results has to consider the fact that this might be generating a pulling force on the posterior myofascial tissues of the back. It might be generating tension stresses in the posterior structures of the lower extremities, as well as the joints. In the spine, the zygapopsyal joints are affected. There's an effect on the intervertebral joints. So again, keep in mind that a positive nerve provocation test reproduces the patient's nerve symptoms. Right? So in the test performance, the patient's going to be sitting. They start in erect position. The hand should be clasped behind the back, and the knees relatively together. Okay. Want to keep the knees as close as possible. Inquire about the pre-test symptoms. The slump preferably should occur mostly in the middle back, in the thoracic spine, as opposed to the lumbar spine. In those people that have more local pain in the back, if you tilt the pelvis and round the lumbar spine, that might be reproducing symptoms in the back unrelated to nerve tension irritation. If that's not so much the issue and the symptoms are just largely in the leg, then it might be okay to have the pelvis rotated posterior and the lumbar spine flex. But according to Butler, the slump should occur mostly in the middle of the back. And you're advising or instructing the patient to keep their eyes looking forward, which is not the tendency of most patients. Most patients, you tell them to slump, they look down. That's not the way we functionally slump, but that's nonetheless what they do. So after rounding the middle back out, then you drop the chin down. This is a patient doing this now, okay? They're actively doing this. It's an active test first. You're not passively pushing the head down. If there are no symptoms, then you can maintain that position with your head-hand contact. You just hold the head. Don't push it down, just hold the head in flexion. Because their tendency, especially when they report, is for them to lift the head. Then the patient will actively straighten the knee on the uninvolved side. If the symptoms are one-sided, have them test the uninvolved side first, then the involved side. And then kind of a common denominator across all the provocation tests. Test the uninvolved side first. The sensitizer would be, if symptoms arise, have the patient lift their head. If the patient has symptoms in the leg, have them lift their head, see if there's any change. Knowing that there's typically displacement in the nerve tract as high as the upper cervical, the lower cervical spine, and tension stress above that. We know there's displacement as high as C8, but there may be additional tension stress all the way up to the base of the skull. Then when you're testing on the involved side, if they lift the head, the symptoms decrease, then go ahead and passively extend the knee further and see if the symptoms are reproduced again. We'll get the variations in a second. Let's go ahead and do this. Karen, come on up. Have a seat on the end, please. All right, so the patient's going to be sitting upright, eyes looking straight ahead. Don't put your hands behind your back like this. Just standardizing the test position to begin with. Then if we can keep the knees a little bit closer together, not forcibly, but just not apart. That'll have, when the legs are extended from this position, especially if you do a bilateral test, there's more influence in the spine less to the hips that way. Okay. So I want you to keep looking. Well, first of all, I need to ask you, now it's best when we're doing this to do some role playing. So how is the pain behind the back of your knee and lower leg today?
Can't feel it right now.
No symptoms right now. Very good. And it's still on the right side, correct?
Yes.
Okay. Left side is all right?
Yeah, I'm having some
Good. Okay, I need you to look straight ahead. And I'm going to put my hand on your back here. And I want you to sort of round your back out in this area into my hand, okay? Okay. So we're getting a little bit of lumbar flexion there. All right, so how are we doing in that position?
feel fine.
Any change in what you're experiencing in your right leg?
No.
I didn't think so. All right. All right, so the next part of this involves active flexion of the head and neck. So I want you to look down, bring your chin down through your chest. So what are you experiencing in this position?
It's a stretch
Where do you feel the stretch?
behind my neck.
It's just some stretching, pulling back in this area here. And how's your leg doing?
Nothing.
Great. So I'm going to just hold your head in this position because I want to make sure that you stay in this position for the next part. So the involved side is the left side. I want you to go ahead and straighten that left knee. Just raise your foot up. Okay, good. And how are we doing with that?
No change.
And go ahead and bend the knee now. I need you to do the same thing on the right side. Raise that right leg up. Good. What do you feel with that?
Little pain.
And where is it?
Behind my knee.
So a little pain behind the knee. Let's just keep the foot still for a second. Would you patient? So a little bit more awareness of symptoms behind the knee. Is that what you're saying?
Mm-hmm.
Okay, so I want you to look up again. Okay, keep your back rounded and look straight forward. Okay, and how does that feel?
Going away. How'd you do that?
So let's keep looking forward like that. I'm going to raise this leg up a little bit more. Does that change anything when I bring your knee into full extension?
Yeah.
What did it do?
It brought it back.
Okay. So let's rest a second. Go ahead back up. So we were able to kind of lessen the symptoms on that right side, and then we also increased the symptoms.
Yeah.
Is that correct? Now notice the questions I asked were kind of open-ended. What do you feel? What are you experiencing? How's the leg? Not. Does that hurt? Does this decrease your pain? Don't bias the answer with your question. Right. So the sensitizers to this test. One was the head lift. Okay, but there's other ways to do it. All right, so we're going to go ahead back into the position that reproduced your symptoms. Round the back, drop your chin down. Good. Raise that right knee now. So what do you experience with that?
A little pain behind my leg.
Behind the leg. And that means like behind the knee and then, okay. All right, so let's, now, the incorrect sensitizer to use in this case would be ankle dorsiflexion. That's the wrong choice. We've already reproduced the symptom. So I want to see if I can alleviate the symptom. I did with the head lift. But the other would be plantar flexion. Okay, so I want you to point your toe down. Okay. So that might alleviate symptoms if the problem primarily was in the posterior tibial nerve. Plantar flexion. But it may actually increase symptoms, especially if you added inversion, if there was issues with the
Tibial.
common peroneal nerve, which nowadays is called fibular nerve. So the fibular nerve is involved. Plantar flexion inversion may actually increase the symptoms, right? There's another nerve that we could evaluate from this position, and that would be the sural nerve on the medial aspect of the lower leg and knee, which is often involved in medial meniscectomies. That nerve can get irritated through knee surgeries. So what you want to do is bring it back into slump position, extend the knee, and then if you're going to stretch the sural nerve, what movements of the ankle would you need?
Inversion, dorsiflexion.
Sure, you're going to use some dorsiflexion and eversion. Right?
Inversion.
It's dorsiflexion, eversion, right? Or inversion.
Eversion, we're going to stretch the medial aspect. All right, so back down, drop your chin down. You doing okay? And go ahead and extend that right knee again. And then we bring the foot up into dorsiflexion. And eversion. Now, maybe more test specific for the sural nerve. All right. Now, there are occasions when symptoms occur when testing the uninvolved side. That can happen. The patient reports, in this case, symptoms when the left leg is extended. If there's a central disc problem, okay, and the symptoms are bilateral, and there's no reproduction of symptoms with either leg, then you might want to have both legs extended. Okay, so there's several different ways you can do it from this position. Let's go ahead and do that again, round the back, drop the chin down. And I want you to raise both feet up to extend the legs. Good. So that's the test position. Or you could have your patient in a long leg sitting position on the table. So any questions on this one?
When you have them in the test position and extend their leg, do you need to have them initially in some degree of dorsiflexion, or is that going to put too much tension through and start biasing them towards the fibular and sural nerves?
Okay, I keep the ankle in what their habitual position might be. I don't change it. I just raise the leg. When I'm doing this passively, same thing. I'll hold just above the ankle. All right, so go ahead and round the back out again. Drop your chin down. So I'm sitting next to them like this, holding the head down. And I'm extending the leg, holding just above the ankle. Okay? So the foot's just going to be positioned in whatever their relaxed position would be there. Okay. Now, if their symptoms are recreated in this position, okay, let's say it requires some dorsiflexion. I might hold it up with my leg and do this. Creates the dorsiflexion. Okay, so go ahead and raise your head now. The symptoms go away or lessen. It's not likely to be the hamstring pull that the trainer told you about or the doctor thinks, because that would be an awfully long hamstring muscle. So you have that hamstring goes all the way to the base of your skull. So it's one way to convince the patient this is something other than just a tight hamstring, which in many cases the patient is thinking, my muscles are tight. When in fact there's a nerve tension quality to it. Okay? Go ahead through this, all the different components of it, all right? Try to role play with it, and then we'll go on to straight leg raise. Thanks. So the question came up about the component motions to stretch the sternal nerve, and I think you've been taught something different than what I remember. So I'm going to go check on that, because I've always been taught eversion, and there might be a different understanding nowadays compared to what I was taught by David Butler. I'll check into that and let you know. So we're going to do the straight leg raise, and this is the most commonly performed neurodynamic test. But it's shown to have pretty significant validity in regards to its ability to diagnose disc herniations. If a patient has a positive straight leg raise test response, there may be a strong correlation between that test response and the patient's reported night pain. If the patient wakes up with pain in the leg or has difficulty getting to sleep because of leg pain, there's a greater likelihood that straight leg raise is going to be positive. A positive straight leg raise test may also be present in those people that have symptoms at rest, unrelated to movement activity. It also has a pretty strong correlation with analgesic consumption. So number one, if the straight leg raise test is positive, you can become suspicious of a disc problem, the disc herniation, and it may relate to the amount of analgesia that the patient's reporting and symptoms that they report at rest or at night. Pain reproduction during what's called well leg crossing or crossed straight leg raise, meaning the patient has symptoms reported in the right lower extremity. You test the left side. That's a crossed straight leg raise test, or you're testing the well leg. If the symptoms are reproduced on a crossed straight leg raise test, this is even a stronger indicator of someone having a disc herniation than if symptoms are reproduced on the involved side. So the biomechanics of straight leg raise. So understand that some people might be feeling nerve tension, irritation just when they're lying down. They already have symptoms in the supine position. Again, you need to assess what their symptoms are prior to the test. That doesn't mean necessarily that the nerve is under maximum stretch. It just means that the position itself is irritating. Understand that tension in the posterior tibial insidic nerve occurs immediately upon lifting the leg. So although there isn't any significant displacement occurring, there is tension, so a patient can have a response within 5 or 10 degrees. Between 0 and 35 degrees, the sciatic nerve displaces in front of the ala of the sacrum. So at some point within the 35-degree range of motion, there is some displacement in the pelvis, okay, right at the base of the sacrum. Somewhere between 35 and 70 degrees, the nerve roots are being displaced in the intervertebral foramen. And then from 70 to 90 degrees, there's minimal displacement of the nerve, but tension in the system becomes more uniform. So the tension becomes more constant throughout the entire neuromeningeal system when you reach 70 degrees and beyond. So in this performance, the patient's going to be supine and typically will have a pillow under their head for comfort. Bring the patient close to the edge of the table. You're going to be raising the leg, so you don't want to be reaching across the table to lift. You want the leg to be near you, and that helps to facilitate handling of the leg, especially when you're going to be moving in various directions. And I typically use a pillow for comfort. Make sure that you're consistently using a pillow under the head, understanding that the position of the head could influence the test result. Okay, so don't use 2 pillows one time and no pillows another time. So you're going to face the patient. You want to be looking at their face. You got a hand just above the ankle and another one just above the patella. Not on the patella, just above the patella. The myoelectric activity in the quadriceps and other surrounding muscles increases as the nerve tension increases. You can feel that in the quadriceps if you're palpating the right place. So the leg is kept extended. You flex the hip in the sagittal plane until symptoms are reproduced. That trumps everything else. You stop the test if symptoms are reproduced. And when we talk about reproduction of symptoms, we're talking again symptoms that the patient reported in the history. And I should say there's 2 pains. There's pain that is initially felt, and then there's the pain tolerance level. And what studies show is that you don't get any additional information or data by going to tolerance. You have enough information by raising the leg to the first pain, P1, we call it. Okay. So if symptoms are not reproduced, you might stop the test at the point of initial myofascial resistance. You could also test to end range. You might test to the point where the knee begins to bend, or the opposite side of the pelvis begins to rotate. So you understand if the symptoms are not, the patient does not have symptoms. Okay, you're raising the leg, you're trying to get information about hamstring length. You have a lot of different ways that you can assess that. And the method in which you assess it could result in a 10-degree difference between you and somebody else. Because if I test to initial myofascial resistance, you test to end range myofascial resistance, we're in a different ballgame here. Or you raise the leg to the point where the knee begins to bend. When the hamstrings become tight, they tend to crease the knee. Or you observe to see when the pelvis begins to be affected. You just need to be consistent in the way you do this. But again, the main thing in terms of neurodynamic testing for pain reproduction is that if the patient reports pain, that's when you stop. All right? Stop at P1. All right, so we'll talk about the sensitizing test as I do straight leg raise. Erica, come on up here. If you don't mind taking your shoes off. All right, so the patient's lying supine, got a pillow under the head. What's the first order of business?
Explain what you're going to do.
What?
Explain what you're going to do.
We're going to explain the test. So I need you to keep your leg limp. I'm going to raise the leg. I want to see if there's any irritability in your nerve tract, okay? I need you to keep your head still. Look it straight up. Okay. So you'll let me know what you feel, okay? What are you feeling in your back of your legs right now? Nothing. Okay. I always wonder about patients that say, I don't feel anything. We all have feelings. Okay, but you do have symptoms on that left leg, right? Okay. And it is down the back of the leg? Okay. in the back of the thigh, knee, it goes down into your lower leg as well? Yeah. Yeah, okay, good. Not good, but I'm sorry about that. So I'm going to test the uninvolved side first, and I'm going to contact just above the ankle. The other hand is above the knee, just above the patella. So I'm not going to yank the leg as, say, the orthopedist might do or the PA. I'm going to raise the leg slowly, and I need you to report it if anything changes, okay? I'm going to make sure that I maintain the sagittal position and not changing the position of the ankle. I'm just going to let the ankle position the way it is. Okay, so you're going to be helpful. So this is a situation where you get a sense of how much the patient how much they want to be controlling. So try to let your leg be limp as much as you can. Now let me do this. Okay, that's better. So raising the leg, this is the well leg raised test. And I'm feeling some initial resistance here in the posterior thigh knee area. What are you feeling?
Just tightness.
So anything change in the left leg? Should I reproduce symptoms as I'm raising the leg up? That would be a positive well-crossed straight leg raise exam, and that might be a pretty strong indicator of a disc herniation. Okay. All right, so I'm going to lower the leg down. So normally I might have the patient over on the left-hand side to test the left leg, but then I'd interfere with you seeing this, so I'm going to be compromising my body mechanics with this. Reaching across, raising the involved side. Okay, so tell me if anything occurs differently on this side. So we're in that 30-degree range now, right? And nothing has transpired yet. So there's been some tension development, but not necessarily any significant movement yet. Right? Movement occurs at about the 30-degree position. So now we're beginning to displace the plexus and the nerve roots in the lumbar spine. And so what are you feeling here?
It's hard to keep the knee straight.
Yeah, I see that. The knee is beginning to bend, and your symptoms are reproduced, aren't they?
Oh,
Yeah. You're feeling this behind the thigh and knee and the lower leg. So let your leg rest. Okay. So what would be an incorrect sensitizer at this point since I've reproduced the symptoms?
Cervical flexion.
Okay, I could have the patient raise their head and neck. That would increase tension on a system that's already displaying symptoms. Or dorsiflexion. What else increases the tension?
Hip flexion.
What's that?
Hip flexion.
Hip flexion. We're already in hip flexion. Adduction and or internal rotation. So all of those would be the wrong choice at this point, right? Correct choices might be, okay, so your symptoms have been reproduced in this position. Okay, tell me if anything changes at this point. So I'm abducting in this position. So what's happened? Another miracle. Or a less sensitizer would be external rotation. That also decreases symptoms, but less so than abduction. Or if the symptoms are maintained in abduction, straight leg raise, what I could then do from this position is add external rotation. Because both of those motions, if stacked on each other, might slacken the nerve even further. All right, so let's say I raise the leg, I get to let's say I'm at 70 degrees. Symptoms have not been reproduced. I know there's been a maximum degree of displacement. I could extend the leg even, or flex the hip even further to create more tension on the system. But say at this point the symptoms still aren't reproduced. Okay. Then I can add additional tension stress by doing all the movements that you just mentioned. In the straight leg raise position, I would then adduct. But I need to make sure that I stack the adduction on the straight leg raise angle. A lot of times what you do is you forget, you lose a little bit of the flexion at the hip, you adduct. Make sure you maintain the position, then adduct. Ooh. So what I felt was some kind of reflex guarding there. What did happen?
I feel it in the back of my calf.
Oh, you actually do.
Mm-hmm.
Okay, so we reproduced what could be a nerve sensation in the calf. Is it still there? Okay. So let me take you out of that position. And is that symptom still there? So we've reduced the tension on the nerve tract and the symptoms have decreased. So that doesn't happen in a stage 2 or stage 3 nerve tension compression. Symptom recovery is delayed in those situations. So I know this is a nerve irritation, probably stage 1 level. All right, so what else could I do in terms of sensitizers aside from affecting the movement at the hip, the displacement at the hip? I could raise the leg. At this angle, I can sense tension in the muscles. The patient's reporting symptom reproduction in the lower leg. What I could do would be to ask the patient to what? So we're going to point the toes down, okay? Try to reduce the tension in the posterior tibial nerve through plantar flexion. And see if that's of any help. Right. If symptoms are related more to the fibula nerve, what I might have the patient do is dorsiflex and see if that would reduce symptoms. Or if I want to increase symptoms in the fibula nerve, we could plantar flex and invert. So you have all those choices. So I need you to go through straight leg raise and go through all the different scenarios to either increase or decrease the symptoms by changing the position of the hip and or ankle. We're going to do some things at the knee in just a minute. We can go through the more traditional standard test first. Okay. Thanks. And the negative straight leg raise test, most likely you don't have a disc herniation. The negative straight leg raise test excludes the diagnosis of a disc herniation in people under 30 years of age. After age 30, a negative straight leg raise no longer excludes the possibility of a disc protrusion. So just because you get a negative response in straight leg raise on somebody who's 55, that doesn't mean you can rule out a disc protrusion. The degree of straight leg raise limitation is proportional to positive disc herniation. So if you have a straight leg raise pain reproduction at 30, 35 degrees, you're more likely dealing with somebody who has a disc herniation than if the test performance resulted in pain reproduction at 75 degrees. Central disc protrusions typically will produce low back pain on straight leg raise. Intermediate located disc protrusions produce back and leg pain during straight leg raise. Intermediate meaning a disc protrusion that's between the nerve roots and or in the axil of the nerve root, okay, more medial. A lateral disc protrusion usually produces leg pain only during straight leg raise. So the location of the disc protrusion is sometimes predictable on the basis of where the symptoms occur. If it's mostly leg pain, the disc protrusion is typically more lateral. If the symptoms are both in the back and the leg, it's usually what's called a medial or axillary disc protrusion. And if the symptoms are not in the leg but the back, you might be suspicious of a central disc protrusion. Pain distribution patterns observed during straight leg raise often don't accurately predict the level of the disc protrusion. Just because you have symptoms in the lateral aspect of the lower leg and dorsal aspect of the foot, that doesn't necessarily mean that that's specific to an L5 nerve root irritation. So you can't always accurately predict the nerve that's involved. You can be suspicious, but you're not always going to be accurate. Positive cross straight leg raise usually indicates more of a central disc protrusion. So after you determine that there is some nerve tension irritability on the basis of a straight leg raise exam, then we're going to palpate. We can palpate in various places. One would be in the posterior hip pelvic region. If you draw an imaginary line from the greater trochanter to the ischial tuberosity and then bisect that, that would be your best point of entry for locating the sciatic nerve as it's exiting out the pelvis. So this is typically done either in supine with the hip flexed 90 degrees or in side lying. I prefer side lying. It's just easier to observe where you are, and I think you can be maybe a little bit more reliable that way. So you're going to palpate in this vicinity, see if there's any tenderness, any sensitivity. You could extend and or flex the knee as you're doing this to see if the tension is either increased or decreased by knee movements. The other location where you can palpate the sciatic nerve, because of its more superficial location, is in the distal aspect of the thigh. So for this, the patient is typically prone. You're going to use a palpation pressure in the distal aspect of the posterior thigh in between the biceps femoris and semimembranosus muscles. So this is the location you're going to be in. So you're above the popliteal fossa. So you can locate the knee crease. You're going to go proximal to that where the biceps femoris and semimembranosus kind of split. Sciatic nerve is fairly superficial in this location. And in patients who have pressure pain sensitivity of the sciatic nerve, they might be uncomfortable if they're sitting and this area is on the edge of the seat, especially in a seat where the seat pan rolls up a little bit. This can be quite uncomfortable. So before we do any of the other variations of straight leg raise, let's go ahead and palpate at these two locations and see if there's any sensitivity. Josh, come on up here on the side.
Facing that way?
Yeah, face that. Let's put this pillow between the knees. bend the knees up a little bit. So locate your greatest trochanter and ischial tuberosity, okay? And then draw a line, draw your imaginary line between the two. You want to be at the midpoint between these 2 points, and use thumb palpation pressure into this location and see if there's any pain reproduction. Okay. Patient has a high degree of nerve irritability. This will be a tender location. And then go ahead over on your stomach. Slide a pillow under your stomach here. Throw this one under your ankles. So here's your knee crease, popliteal fossa. You're going to go up proximal to that. You can locate the biceps femoris tendons and the medial division by a contraction. Have them resist the extension. Locate the biceps femoris tendon, semimembranosus. Okay, let go. You want to be between the two while I test pressure into that location. If they have no pain upon pressure with the knee flex, go ahead and extend it. Extend it all the way, be in the same location, see if there's any sensitivity with the leg in a straighter position. Go ahead and turn over on your back. All right, so we'll do the Lessig test. Move over to the right just a little bit. So in the Lessig test, the patient's reporting a posterior pelvic pain. So this pain in the buttock. You're raising the leg. You get to some point during the range, and the patient reports, yeah, I feel pain in the buttock area. Okay. So what you're going to do is bend the knee. Now, if it's a nerve tension irritation, the bending of the knee, which is a sensitizer, should lessen the tension in the sciatic nerve. The symptoms should be reproduced. If the symptoms remain in the posterior pelvic region, okay, it's from another tissue source. It could be related to many things. It could be a posterior capsular irritation in the hip. It could be an SI that's being irritated secondary to the posterior rotation. It could be just a stretch to the gluteal muscles. But you're incriminating some structure in the posterior hip and thigh area if the symptoms are lessened on knee bend. And that's what a Lessig test is. It's trying to differentiate out between local tissue irritation in the posterior hip pelvic region versus nerve tension irritation. All right, so do the palpation tests and do a Lessig test, okay? On the straight leg raise exam is called the bowstring test. Okay, the bowstring test, we're trying to confirm the previous results. We're using palpation pressure to assess the irritability of either the posterior tibial or the common fibula nerve. In this case, the leg is being raised, as in straight leg raise, and then you're going to flex the knee. So the sensitizer is performed by bending the knee after symptoms are reproduced. Okay. If the symptoms ease, okay, then manual pressure is used onto the posterior tibial nerve. Okay. So you're applying pressure at the knee crease within the popliteal fossa. onto the posterior tibial nerve after it splits. Okay? And you can add ankle dorsiflexion, plantar flexion, or alter the position of the knee to increase or decrease the tension. Okay, so straight leg raise is performed, symptoms are reproduced. The sensitizer you choose in this case is a slight flexion of the knee. Okay, just the symptoms are decreased after 5 degrees of knee flexion. You then palpate in the popliteal fossa onto the posterior tibial nerve to see if symptoms are then reproduced secondary to pressure provocation. The test is considered positive if the symptoms are reproduced with palpation pressure. So you could also palpate the common fibula nerve in the posterior knee popliteal fossa area. For the posterior tibial nerve, you're going to be centrally located. You're right in the middle of the crease. For the common fibula nerve, you're going to be just medial to the biceps femoris tendon. Or the other location you could choose would be just inferior to the fibular head. Now, if you want to alter the tension on the fibular nerve, again, you could dorsi or plantar flex the ankle. All right, we'll do the cardiacs in a second. So, Justin, come on up here. Test the right side. We're raising the leg. In a standard straight leg raise. We get to 45 degrees of straight leg raise. Symptoms are reproduced. So you select the sensitizer to try to decrease the symptoms. In this case, what we're doing, because we're choosing the bowstring, we're going to bend the knee. Let me know if anything changes. We flex the knee just a few degrees, and Dustin says,
Pain's gone.
pain is eliminated. All right. So now your thumb is going to find the knee crease. Okay, you're going to be centrally located right in the popliteal fossa. You're going to apply a pressure into the posterior tibial division of the sciatic nerve, and that pressure is bowing the string, bowing the nerve. And that's how the name of the test came to be. And the patient then reports
Pain's back.
pain is reproducing it. Positive bowstring. If the symptoms seem to relate more to the fibula nerve, what you will do then is to offset your test pressure just inside the biceps femoris. So you're going to be more lateral. Same thing, you raise the leg, and at 45 degrees, symptoms are reproduced. Sensitizer you select is slight knee flexion. This time you're going to palpate inside the biceps femoris tendon and see if that test pressure produces symptoms. Okay. If it doesn't, the fibula nerve is involved, what else could you do to try to increase the tension? We could create some inversion and or plantar flexion at the foot, right? The other location where it might be sensitive would be just distal to the fibular head. So locate your fibular head, okay? And you've partially flexed the knee to reduce the symptoms. Palpate in this location, see if symptoms are reproduced. Okay, so these are additional tests to try to help support your traditional straight leg raise exam. And again, I just want to emphasize selecting the appropriate sensitizer. If you've reproduced the symptoms on the standard straight leg raise, the appropriate sensitizer is to decrease the symptoms. Okay, whereas if the symptoms are not reproduced, then you add additional sensitizers that would increase the tension. Okay. So in this case, we've done both. We've decreased the symptoms momentarily by bending the knee, and then we've increased the symptoms through direct palpation. Okay? Try the bowstring test out. In the cervical spine, it can be partly determined through slump sit test because it involves head to neck flexion. But there can be further information using a test called Kernig's. This involves neck flexion, which is done either actively or passively, actually. And it's used to assess the extent to which the neuromeningeal system is involved in the brainstem, cervical spine, and less so in the lumbar spine. So it involves a top-down movement performance. What we do know is that cervical spine flexion will displace the cervical spinal cord about 5 millimeters, the thoracic cord 4 millimeters, and the lumbar nerve rootlets about 1 millimeter. So if you just bring your chin to your chest, you're generating force all the way down into the lumbar spine with respect to the nervous system. All right, so this test is done in supine position. There's 3 options. Okay, the first one actually is active, where the patient actively lifts the head and neck, chin to chest. And the patient will report to you if there's any symptoms upon active neck flexion. If no symptoms occur, the second part of the test would involve the patient actually passively lifting the head and neck and applying a little bit of an overpressure in cervical flexion. And then the third test, should that be necessary, would be for the examiner to do the same. There's also the option of linking passive neck flexion with straight leg raise to provide additional support for neural tension. So now you'll be basically generating tension from above down and also below up. So as the operator, if you're in the third step of this procedure, you're holding the head up into neck flexion. All right, so if you're going to add a straight leg raise exam, the best way to do that is to have the patient start in hook-like position with one knee crossed over the other. So what they will do then is extend the lower leg, okay, which puts additional stretch on the sciatic nerve, secondary to knee extension, hip flexion, and a little bit of adduction, actually. Okay. So, Taylor, come on up. And Mariana, you back. So you have a positive slump test that occurs secondary to chin to chest position. The symptoms are reproduced. So you're suspecting that this neuromeningeal system might be implicated all the way up into the cervical spine. So it would be appropriate to do a Kernig's. The Kernig test, again, the active part of the test is asking the patient from the supine position to lift the head to bring the chin to the chest. So let's do that. Go ahead and raise your head, chin to chest. Okay. And they are to report to see if symptoms occur in that position. Okay, back down. So no symptoms have occurred, so now you go on to the second part of the test. So I want you to put your hands behind your head this time, and I want you to lift your head using your arms, and then create a little bit of an overpressure. So additional force generated for cervical flexion. Again, the patient reports no symptoms. So then you would manually apply the force as the examiner. You lift the head and neck, do the same maneuver, but now you're getting a better sense through palpation about the tension in the system. Okay. again, if they've had symptoms in the 2 previous tests, this is not necessary. So in this case, we're raising the head and neck. Taylor has no symptoms at all through passive overpressure from the examiner. So now I'm going to ask you to bend your knees, and I want you to cross your right leg over your left. Okay, see, that's the way we're going to cross it. It's a knee cross position versus an ankle cross position. And then when I ask, what you're going to do is just raise this leg up, okay? So lift the head and neck into a passive flexion. Overpressure, let your head rest completely. Okay. And no symptoms have been elicited in this position, so the patient then is going to raise that right foot using the bottom leg for leverage. Okay, so we're in a 70, 80 degrees of straight leg raise position with a little bit of adduction. We have stretched from above down and from below up. Okay. Then, of course, you test the other side. Right. Now, one comment about straight leg raise. In terms of what normal straight leg raise angle should be. And of course, that's going to be quite variable depending on age and functional need. So, a number of years ago, working with an Atlanta ballet dancer, I was raising the leg, I was lifting the leg, and I kept lifting the leg, and I got to 90 degrees and thought, maybe, should I stop here? And I didn't feel any resistance, and I kept going, and I kept going, and I virtually was getting the thigh. Are you okay?
Yeah.
That's the reason I selected her. I had the thigh basically pressed on her chest. And at that point, she said, I'm kind of tight today. And you know something? I was inclined to believe her. Because her functional needs are beyond the typical or average person. Right? So in that case, straight leg raise, normal straight leg raise angle was like 140, 150 degrees. Now, if I'm testing a 55-year-old man and I get to 60 degrees, that's probably a pretty good day. And they'll probably say, yeah, I stretch my hamstrings every day. How are they? Pretty good? Really good. Very good. So keep in mind, again, age and functional need of the patient when you're doing straight leg raise to determine whether this leg raise is normal for them or not. All right. So let's finish up today with the Koenigs. And then we have femoral nerve to do in prone, lateral femoral cutaneous nerve to do also in prone. I think we have saphenous nerve as well, and then some of the upper limb nerve tests to complete on Friday. We might be able to get done and start on some of the neuromotor tests as well. So go ahead and complete the Koenig today.